Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hi, and welcome back. I'm Dr. David Kaufman.
And I'm Dr. Eileen Ruhoy.
Hi. And this is going to be part 2 of our conversation on POTS, or hypoperfusion syndrome. I like that new name. We were going to do this episode on SIBO, small intestinal bacterial overgrowth, another passion of mine. But POTS is too important, and we couldn't say it all in the first episode. So this is part B. I don't know what we want to call it.
No, we're going to just do another episode at 11.
All right.
Although, yeah, maybe 10B.
All right. So this will discuss treatment. And that's a huge topic. I don't even know if we'll be able to finish it in this episode either, but certainly we can get started.
Yeah.
You want to...
So where does it start? I mean, so we've diagnosed POTS and everything that goes along with it.
Right. And
we've done some workup. So sometimes we can stratify whether it's hypovolemic, hyperadrenergic, neuropathic, so we can stratify it, which can sometimes tailor treatment. But I think it all starts with a little bit of the same, right? And that's usually more conservative kinds of treatment.
Right.
So compression gear is the first thing I always recommend.
Right.
There are compression socks. Oh, I'm wearing compression socks right now.
Beautiful.
But I always tell people that I think that for POTS, I think that the abdominal binders are actually way more effective. And these days, females at least can wear Spanx.
Right.
If they want. I'm sort of against those as a feminist, but regardless. But you can wear Spanx as opposed to the girdle kind of abdominal binders that are not that fashionable. Because, as I said, the pooling of blood is often, it definitely goes down to your feet, but is also very much contained in the splanchnic mesenteric bed. And so it very much helps blood return by compressing more of that region. But clearly, if you have the kind of POTS where there's bluishness, where your feet turn blue, where there's swelling, where you start to feel abnormal sensory concerns of your feet, then there's a lot of blood down there, and then compression socks, I think, will definitely greatly help.
Yeah, I think that it's very important. I have not had much success. I find that they're uncomfortable for most patients, compression and certainly the binders. Many of the patients already have skin sensitivity because they have mast cell activation, so they have allodynia and things like that. So, they should work very well, but most of the time, most patients don't like it and they don't wear it. So, but it is an appropriate starting point for sure.
Especially if people are trying to avoid pharmacologics initially, which a lot of patients are. They don't really want a bunch of medications just yet.
And then similar early immediate recommendation is always fluids and salt. I think my patients are so sick of hearing me say fluids and electrolytes, they want to scream.
Yeah.
But it is all about fluids and electrolytes.
It is, but it has to be consistent and regular, as you know.
Exactly.
And what's interesting to me is that you would think that, if you just give a volume of liquids, even IV-wise, there would be immediate response, but there often isn't. And it just speaks to... It's not just about hypovolemia, and in fact, we know that there is adrenergic and pseudomotor dysfunction of the peripheral vasoconstrictor responses. So there's more going on in terms of the autonomic dysfunction that I always try to manage expectations, that I think that just replenishing with fluids and electrolytes is not going to be the complete answer, but will certainly minimize the symptoms for sure. Right. And I focus on those electrolytes because I always explain if you're just going to drink a lot of water, your kidneys are still functioning perfectly fine. It's just, the kidneys, their whole purpose is to manage, salt and water, and where salt goes, water goes, and so you have to replenish it with electrolytes to increase the osmoles in the fluid so that the kidneys are fooled into thinking that it doesn't have to excrete all that free water to help, once again, balance the osmolality.
Right. So these are really important points.
Yeah.
So let's spend a little more time on it and get maybe some detail. So in terms of fluids, Yes, it's not. If I suggest to a patient they drink more fluids, that doesn't mean they should go home and quickly down 3 quarts of fluid. Okay, it's spread out through the course of the day. Generally, we say a normal, healthy person in no distress should consume about 2 quarts, 2 liters of fluid a day. That's not adequate for our POTS patients. They need to be upwards of 3 to 4 or even 5, which is daunting. That is not easy to do, especially because you just don't think about drinking all day long. So it's hard, and I will suggest that they use a water bottle, first of all, so that they have a measurement, and then they know how many times they refill it in the course of the day so they know how much they're drinking, and that they just keep drinking, take sips, rather than, glug it down.
Right.
All right? And it should be 3 to 5 liters a day, which is a lot of fluid.
A lot.
It's useless if they don't have electrolytes.
Right.
And, many online, many of the things you'll see will be 5 grams of salt. I don't think that's very good. I think you need electrolytes with an S at the end, plural, okay? So particularly sodium and potassium. And I routinely will try to encourage them to buy electrolyte supplements. I try to get them to get the ones without sugar. Most of the readily available have sugar. Gatorade is about the worst example, okay? A lot of the sports electrolytes that athletes use and workout people have sugar in them, or other sources of carbs. Not so good. It's why I really like. Are we allowed to use company
Why not?
names?
I do it all the time.
It's why I really like Vitasium and their salt
I love
tablets
Vitasium.
or salt sticks. It's just sodium and potassium. They're easy to take, and I can see, patients can tell me the difference if they take 2 in a day versus 6 in a day. So it's a really easy fix.
I agree. I recommend that all the
works.
time, and I usually get a lot of free samples in the clinic, and I just give them out very liberally. I agree. I try to ask them to avoid the sugar ones, but there's in the stores these days, of course, there's the Emergen-C.
Yeah, they're all over the place.
Right.
Even
and the Noon
Trioral,
tablets.
the WHO Trioral, I think it is, has sugar in it because that's for patients with cholera, and that's not what we're talking about.
And what do you think about that liquid IV?
Yeah, that's not bad.
Yeah.
Patients like it, and
patients seem to give me good
pretty
feedback on that.
Yeah.
Yeah, I'm definitely not brand specific. I mean, if a patient gets a good response and they like it, then I'm all for it, because the truth is it's like everything else. Like if you enjoy it, you'll do more of it, right? So if they happen to like the taste of, especially a lot of my teenage patients, if they like the taste of it, they'll drink more of it.
It's whatever finally gets the patient to,
exactly.
makes it easier for the patient
it's like with exercise.
to do it. Right, exactly. And I would add that we're going to get into some drugs and treatments. I'd sort of argue that none of the treatments we're going to discuss work in a volume-depleted patient. They have to do the fluids and the electrolytes. Otherwise, we're wasting our time.
That's very true. Because most of what we try to do is to act upon keeping the volume there.
Right.
But if it's not there to begin with, then we're already starting at a negative. Right.
Exactly.
So I agree. So yes, fluids and electrolytes. I mean, it's just the cornerstone of treating POTS for sure.
And I would add something I think I may have said in the previous episode, that it's pretty well accepted that in the ME/CFS world, at any rate, all of the patients, or nearly all of the patients, are volume depleted, probably because they all have hypothalamic pituitary adrenal axis dysfunction, which means their aldosterone and or their ADH, desmopressin, are not properly produced to tell the kidneys to conserve fluid. So again, it's not just one reason, and it's all connected together.
That's right. And I always check. I do. I mean, we check
those
as part of the workup to sort of see where where a deficit may lie. So fluid and electrolytes, compression gear, those are sort of the, and the other conservative measure is what we talked about in the last episode, but worth repeating here since this is its own episode, which is that counter maneuvers can sometimes be helpful at minimizing symptoms when symptoms are presenting. So like things like crossing the legs, of course, and and allowing the body to calibrate. So when I always say to patients, when you wake up in the morning, just allow yourself to lie there for a couple of minutes and allow your body to wake up and come back online, because it doesn't. And I always say take some deep breaths, get the oxygen flowing, get the blood moving, and then sit up slowly. And I always recommend not sitting up straight up, to sort of go over to your side first, because there's a lot of, you don't want to pull upon any muscles that are not yet ready to be pulled upon from being supine all night long, especially in these connective tissue patients. And then so go to your side and sit up slowly, put your feet on the floor, allow it to calibrate for a couple of minutes. And when you're feeling steady, stand up slowly, hold on to something if you have to, or just stand for a couple of minutes and allow it to recalibrate again,
Right.
and then take your first steps. I think that's real important, and it's a good way to start the day. It's a safe way of starting the day. I always think about in the morning, especially with the HPA axis abnormalities and with regards to even cortisol. It's well known that things like strokes and heart attacks occur most often first thing in the morning.
So let's give a little of the physiology there, because
Okay.
it's important even for, quote, healthy people.
Yeah,
okay?
no, absolutely.
So when you first wake up in the morning, that is your most dehydrated state.
Most
you have
dehydrated
not had
state. No, most dehydrated
most dehydrated. You have not had fluids for at least usually 8 to 12 hours often.
Right.
So you're already volume depleted. And if you are one of our patients, you're now multiply volume depleted.
Correct.
Okay. Secondly, the cortisol levels in our body are at their highest when we first wake up. I mean, that's evolution again. You want to have cortisol so you can get out there and hunt. Okay. So it starts up high and it comes down.
Or gather.
Or just wake up. So if it's true, which it is, that nearly all the patients have an HPA dysfunction, they're not going to have that cortisol spike in the morning. So now they have another reason to have problems. So, it's actually amazing to me that I don't get more calls and emails and messages that I fainted this morning,
right,
or that I hit my head when I got out of bed, because that's the riskiest time. And that's true for healthy people too.
Yeah.
I mean, I for those of you who are healthy, it's a good idea to do exactly what Eileen just said.
Absolutely.
Sit on the side of the bed, count to 20 or 30 before you then stand up. You got to warm up. Think of it like
it's a warm up for the day. No, that's exactly how I explain it. And then I usually sort of add, like I tell patients to try to go outside and get some morning light, because it helps the circadian rhythm of the brain, because our brains are circadian organs. And obviously, as I've already said, the brain plays a role in the autonomic nervous system and its function and its responses. So I try to get them to start out their day at least a step ahead, and trying to prevent and minimize. And obviously, I haven't done any randomized control trials that this is actually helpful for patients. But one, it's healthy, that I know. It's easy. It's free, and it's just safe. So so I feel good saying it, and I'm really happy when patients will tell me about how they follow all of my instructions and they feel good. And now it's like a matter of routine, which it certainly is for me. That's my routine every single morning. So these are the conservative measures, non-pharmacologic, and
I want to digress for a minute.
Okay. I love digressions.
So in the previous episode, you asked me towards the end, I think, what's your workup on these patients?
Oh, right.
Okay. And I want to just add in 2 more things. I don't think I was clear. So I think the workup for the HPA axis is critical. I use a saliva cortisol testing modality because it gives us the 4 time points in the day, so I can actually see the spike, the morning spike, and then the gradual decline. And it's measuring free cortisol, which is the active form of cortisol in the body, not total, which includes 90% of inactive cortisol. And it's unbelievably revealing and easy to do. I mean, it's cost a little money, but you just home spit into 4 tubes. That's all it takes. Spit into 4 tubes. And you don't have to do it for a female patients based on their cycle. So that's crucial. And then I won't get into this too much, but I will also always look for SIBO, which we'll get to maybe next episode, because again, all these things interact. If you have SIBO and leaky gut, that's going to affect your POTS, your volume, everything. So is it just a plug for this idea that these things are all related to each other?
And I'm glad you explained that, because that was really important for them to understand that the cortisol plays a very important role in all of this, and it's easy to test, but it has to be tested appropriately. And so you explained that very well.
Thank you.
I think the workup is important, and that's what we said. I mean, the reason why so we talk about how there's criteria to meet for POTS diagnosis, and that's fairly easy to do, the tilt table, Nasaline test. Exactly. But the workup is so much more extensive for all of these reasons. And as we go through more treatment options, and it can tailor what we do. It could tailor how much we do initially. It could tailor what our second tier of treatment is. So the workup is super important. And if there is an HPA axis abnormality, it's important that we know it earlier rather than later, right? So that we sort of know what to expect, and we can manage expectations with regards to any kind of intervention that we recommend. So I like knowing all of this stuff about patients. I like knowing their glucose level.
Well, there's a reason my initial workup is 35 tubes of blood. So.
Exactly. Right. I've been accused of ordering too many labs, not by patients, but by other doctors.
I have a little story, a humorous story.
Yeah.
I went to have my own blood done last week to one of the draw stations in Ballard. And she says, the room's full of patients, okay? She says, David Kaufman, wait a minute, are you Dr. Kaufman ordering your own blood? So she laughs about that, and I say, wait a minute, are you the Dr. Kaufman? You're the one who sends those patients in with 35 tube draws? It was really,
do you warn patients? Because I always do.
I do, but it was very funny. I mean, she was really nice, and that draw station's great, but it was very funny. Totally took me by surprise.
How did you feel after 35 tubes of blood were taken?
Tubes.
Oh, you
I wasn't doing my. I was getting my own blood drawn.
Got it, for your own reasons.
As a good
got it.
Heal thyself doctor.
I always warn patients, this is a lot of blood that I'm taking, a lot of tubes. Yeah. So you might feel a little tired afterwards.
Right. I always tell them, hydrate well.
Hydrate well. Bring some crackers.
Anyhow, sorry for the diversions. Okay.
So then, all right. So after the conservative measures, are there any other conservative measures that you recommend? I mean, I talk a lot about breathing exercises. You know, when we inspire, we actually move CSF flow, and we also we invoke our autonomic nervous system with respiration, which is one of its major goals, by the way. It's sort of to control of respiration, especially of the brainstem nuclei. So I like to sort of invoke that a little bit, and I talk about some breathing exercises, which I'm particularly fond of. You know, not only like deep breathing, but there's something called 4-7-8 that I have them do, a 4-7-8 breathing exercise, and I'm not so sure it's worth it.
I don't know what that is. Teach me.
I actually learned it from Dr. Andrew Weil when I did my integrative medicine fellowship at the University of Arizona, and I use it for all kinds of reasons, but it's remarkable at sort of invoking vagal tone, which I think is a real important mechanism for any kind of autonomic dysfunction, frankly. But basically, you sit in a comfortable position, and you breathe through your nose, counting through 4 to 4, and you have your tongue. You
mean one inhalation for 4 counts?
One inhalation through your nose, and you count to 4, and you hold and you have your tongue, your tip of your tongue sitting on your upper palate and the upper roof of your mouth, and then you count in your mind to 7, holding your breath. And then you exhale through your mouth and count to 8. So a very prolonged exhale. So you breathe in through your nose, 4 counts. You hold your breath for 7 counts. You breathe out through your mouth for 8 counts. That's the easier way of explaining it.
And do you do this repetitions, reps?
Yeah, you do it. I generally say do it 3 to 4 cycles of it. And it's remarkable how relaxed you can feel. So built into your day, or when you feel the need? I always do it in the morning. I do it every morning. Yeah. I'm a weirdo. You must know that about me by now. But I definitely do it when I wake in the middle of the night and can't go back to sleep because my mind's racing. Yeah. So I recommend that to my patients as well who have any kind of sleep fragmentation because their mind's racing. Although we know that circadian rhythm disorders is common. What? I never have trouble sleeping. So. You never have trouble sleeping? Well, you should try this. I'm going to. And then certainly if I'm feeling like any stress during the day, like I'll do it. I will try that. I can remember that. So I go through with patients in the clinic, and you're going to laugh at this, I know, but I even in the clinic, although I really miss my clinic appointments, but I do a lot of telehealth now. But in the clinic, I teach patient visual meditation. So I'll go through a visual meditation session with them. My voice is not that calming, though, unfortunately, because of my New York accent. But I do try to teach them how to meditate a little bit on their own. And I help them visualize things. Right. And so I find that all of that can be really calming for a patient. And again, it's free, easy, and cheap. Free and cheaper, I guess the same thing, but and easy to do in their own homes. No equipment needed. Right, no equipment needed. So I do all of that great. That's great. And that's what I recommend to patients. That's what I give patients as a morning routine. That's very good. I like that. I'm going to try the 4-7-8. 4-7-8. I'm telling you, I am a believer. It is remarkably effective, and it's something about the breathing in through the nose and the holding of the breath, and then breathing out through the mouth that does something to it almost resets it. I wouldn't say permanently it's somewhat transient, but if you can capitalize on that, then you really are, you're a few steps ahead. So, anyway. So other things, conservative, non-pharmacologic, relates to stuff we talked about in the previous episode. Advising people not to stand still. Right. Okay. Right. So behavioral stuff. Right. Walk around. And one of the examples I give is, if you've ever been in a hospital and you watched interns, residents, medical students, and the big attending making rounds, you'll often notice that the residents and interns are bouncing up and down on their toes. They're up, and that's because they're flexing their calves to get their blood to their heart so they don't faint like those old movies with a soldier who faints after being at attention. And you can do that.
It's really important. Same thing, even
Absolutely.
if you're on an airplane, you want to be stretching, flexing your leg, your ankles to contract your calves and push that blood up.
I agree. Leg exercise. The stronger your leg muscles are, the better the pumping will be to improve venous return.
Even just swaying.
Yes.
Which,
Actually,
by
I
the
think
way,
swaying is good.
on the lean test, I meant to say this. I almost said yesterday, but I mean the previous episode. The reason we have, and patients always ask, why are you making me do this way? The reason they're asked to lean against the wall is and not do any of the work. Somebody else does the work. Their arms just hanging to their side. Is to try to prevent them from contracting their muscles.
Yeah.
Because most of the patients with POTS have learned unconsciously that when they're standing still vertically, they will try to shift their weight and contract the muscles, and then that throws this off.
Right. Same thing with the tilt table. That's why they're strapped into the tilt
Exactly.
table, because when we just automatically tilt you up, head up tilt, and you're not using your leg muscles because you're.
All right, we're never going to get through this. Let's go back to treatment. Sorry. Okay.
No, but there's a lot of concern, and I think honestly, I'm all about conservative measures when you can implement them, because I think that's important.
Yeah, for sure.
Man can't live on medication alone.
And as part of those, as physicians, one of the things, or that I do, and I'm sure you do too, is bring it up over and over.
Yes.
Okay?
Oh, yeah.
So when the patient gives me their lean test, the first question I'll ask, even though I've asked it a dozen times, how much fluids are you drinking? How much electrolytes are you taking? And unfortunately, often it's, I kind of fell off the wagon.
Yep. Yeah, they're usually very good initially, and then they fall off the wagon. Yeah, I know. And I sometimes we'll just order IV fluids just so they'll get regular IVs.
So I was just going to bring that up. So it's interesting. This is a big leap from Pharmacologics for a second, because I don't start with IV fluids. But they are frequently given, and they can be remarkably effective and successful. What's really fascinating to me, and I don't have an easy answer, I have an idea, but I don't know for sure. You give a patient a liter of fluids, and that will last them. They will have benefit for 2 to 3 days, even 4 days and 5 days. 1 liter. So and I know that we're peeing that liter out within a day, within 6 hours. So why do they have that benefit still?
I think it has to do with the baroreceptor, right? So I think that it senses that, at least for now, there's enough volume and the pressure is okay.
Right.
So it doesn't really do anything that would alter the
more salt than they probably have, which helps retain the fluid.
It certainly helps retain it. Yeah.
But it's really interesting.
Yeah, I completely agree.
It's not a great treatment just because it's a pain in the neck to do IVs twice a week. Or
right. No, and again, as I said earlier, it also doesn't seem to be the magic cure. Otherwise, that would be great. So there is some level of, again, peripheral vasoconstrictor abnormality that's not sort of helping sort of keep the volume in and push the volume back up to where it needs to be, and to help improve cerebral perfusion, which is ultimately what we know to be the case with POTS, and that's why they have all these symptoms.
All right, so let's go to some drugs.
Drugs. What do you start with? Do you start with the beta blockers?
I usually start with beta blockers, or I start with volume enhancers. Okay.
I call them vasopressors. Is that not accurate?
No, I wouldn't call this vasopressor. You mean like fludrocortisone?
Yeah.
No, I think of vasopressor like dopamine in the ICU. And I think it's not an easy decision to make. Even though I just finished saying over and over and over how all our patients are volume depleted, therefore it would make sense to use an agent to enhance volume as first-line therapy. The problem is I find it hard to make that decision if, when the patient does their orthostatics, their heart rate goes to 150 or 140. You feel like that's the priority. I got to slow that heart rate down.
Right.
And again, let's teach the physiology here to be sure everybody understands. There's nothing inherently wrong with having a heart rate of 150. When I work out or you work out, the goal is to get to 140, 160. It's assuming we don't have coronary artery disease, that's okay. All right. The problem is that when you have a rapid heart rate, the heart doesn't have time to fill from the venous blood that's coming in across the right heart. So it's a filling pressure issue, and it's a time issue. So if you're just beating slowly, it fills. As soon as you speed up that rate, it doesn't fill as much, and therefore, as you said earlier episode, the cardiac stroke volume decreases, the cardiac output decreases, the blood pressure falls, you develop hypoperfusion, and bam. Okay. So I tend to see that as the priority initially, and therefore almost always start with beta blockers. But I often am concerned, and I really want to hear what you have to say about this, that the reason they're going at 140 is because they're so volume depleted that this is a completely appropriate response.
No, that is how I see it. That's exactly how I see it.
So it's
and when I think about, as we talked about the baroreceptors, the chemoreceptors, I just think it just needs to see more volume, and then it'll correct itself. Is how I see it. But I don't disagree with what you said either. Like I don't think anyone really knows the answer.
So I go in phases. What happens, and if I don't think the patient's doing what I said with fluids and electron, they're just not able to, or they can't. Then I'll probably go to the fludrocortisone type drug first. So let's say what that is. So to increase volume, besides fluid and electrolytes, we can tell our kidneys to do some things. Okay?
Hold on to the sodium.
Right. So fludrocortisone is a synthetic version of a hormone that we make in our adrenals called aldosterone. And it very simply sends a signal to the kidneys to conserve fluid. And the kidneys do it by activating or using a pump. And that pump keeps in sodium and throws out potassium. All right? And that water follows
sodium,
the
potassium, ATPase.
Right.
On the renal tubules.
You got it.
I remember physiology.
Remember medical school. Very good. So that increased sodium allows the body, so to speak, to hold on to more water, and that increases volume, et cetera, et cetera, et cetera. It's very important to tell patients and to understand that it's a pump, and what's getting tossed out is potassium, and if your potassium goes too low, that's equally bad, egregious. So they need to supplement with potassium. Usually diet does it. You don't. I rarely give potassium prescription supplements, but it's important to tell patients that. And fludrocortisone can be fantastic. I am often disappointed, however, and I don't know what your experience is, many patients just can't tolerate it. They immediately get headaches, almost right away. Maybe that's a signal for this 800-pound gorilla intracranial hypertension that goes underdiagnosed, but it becomes a big issue. But that would be the initial volume enhancement.
Yeah, I use remarkably tiny dosages of fludrocortisone because I was having the same problem. And I find that with, what I would consider, or at least once consider, subtherapeutic dosing of fludrocortisone, I use now. And
what do you start with?
It comes as 0.1s.
Right.
I tell them to cut half and do it once a day.
Right. So I always start that way.
Yeah.
Sometimes,
and you still get
sometimes even 0.025. Sometimes I do, not always. Okay. But yeah, I think with all our patients, as a general rule of thumb, we always start low and go slow and taper up.
Yeah, for sure.
Which is why I also use the lean test so much, because then I can see if it's working.
Right.
Which actually brings me to something I just want to say in general. When I have a new patient and I say, let's try fludrocortisone, and they say, no, I took that, it was terrible. Didn't work, I felt horrible. You can't accept that statement. At least I can't. I need to know what dose they took and for how long.
Oh, gosh, yeah.
Because sadly and routinely, most physicians, if it's fludrocortisone, they'll start with 0.1 to 0.2, which is
twice a day.
But 1 to 2 times the dose I would start with. If it's a beta blocker, we'll get to the blockers in a minute, they'll start with a dose that's literally 4 times what I would start with. So we can't as physicians assume that when a patient says they can't tolerate something, it means they can't tolerate that drug. It just might mean they can't tolerate the dose they were given.
Oh, yeah, and absolutely. And of course, our patients come, they've already seen a bunch of doctors, they've been suffering for years. So I'll bring up a recommendation for medication, and they'll say, I once took that 4 years ago.
Exactly.
I didn't feel well, I stopped it.
Right.
And let's revisit that.
And the flip side of that, same problem, but the flip side is, I took that 4 years ago and it didn't help me at all.
Right.
What dosage did you take?
Right.
How was it monitored? How was it measured? Did you take 5 milligrams and then titrate up? And, so it's really important. It's not that I disbelieve the patient.
No, of course not.
It's that the information is incomplete.
Right. And their experience might be different now, too, by the way, right? So years later, obviously, our physiology changes.
Right.
And sometimes what didn't work before will work now. I mean, and I'm always amazed at that as well. I always retry things, assuming, of course, that a patient didn't have an adverse effect, right?
Yeah.
I will sometimes revisit medications at different dosings, especially if another medication is now on board.
Absolutely.
And I think this could be a good adjunct kind of
synergy.
therapy.
Right.
Yeah. So it's like being a chef in a kitchen.
Yeah,
That's what
a
I
little
always say.
pinch of this and a pinch of that. All right, so beta blockers. Anything else on fludrocortisone?
No.
Okay, so the other volume.
I really like it. I like it. You know, I will say just one thing about fludrocortisone. I think I find it works better on my younger patients than on my older patients.
I agree.
So that might have something to do with what you were saying, that they all get
I only,
headaches
by
and
the
stuff.
way, give it once a day. I used to give it twice a day, and then I read some literature that suggested no, and I find it actually once a day in the morning is very effective. The beauty of it is it's just one pill a day, so it's really easy, and it can be remarkably effective for patients. The other drug that can enhance volume is has many names: antidiuretic hormone, desmopressin, DDAVP. I think I'm missing a name. Anyhow, that's a
Those are the
hormone
ones I
from the
refer to
brain
as. Yeah.
that tells the kidneys what to do, conserve fluid. It works a little differently, and I'm not actually sure how it does it. I mean, it doesn't use the sodium-potassium pump, but it's very potent and can increase volume. I use it less often because often patients have an adverse reaction to it, and because it has one very serious potential side effect, and that is working too well, and they retain too much volume because I've been drilling into their heads to drink so much fluids. So now they they drown in their fluids, literally, and their sodium gets diluted down, and they become hyponatremic. The sodium's too low, and that is very, very serious problem.
Very serious, and that's actually happened a couple of times. And so I tend not to go down that route with that line of medication.
I do still use it, but I'm very adamant about safety labs. Initially every 2 weeks, and then as we see how it plays out. And with some patients who've just been, I can't make progress, I've even used both drugs together with some success.
And I mean, it works directly on the posterior pituitary, and I think one of the reasons why I also try to avoid it is because my patients already have problems with the HPA axis. So like I'm just trying not to directly affect the axis. Obviously I'm trying to come around, more indirectly kind of work. But and especially in terms of the regulators, like in terms of like focusing on the hypothalamus and the pituitary, like I tend to avoid that and want to work more downstream to sort of help support and boost the autonomic nervous system to help retain the fluid appropriately. But
we probably should just say that if we have evidence of HPA axis dysfunction and low cortisol replacement in subtherapeutic, subphysiologic, lower than normal doses can help with volume as well.
I agree.
Along with a million other symptoms.
I completely agree with that. I definitely support the adrenal glands when I see hypocortisolism, which a lot of our patients have, of course. So, and it contributes to all these symptoms. So you have to fix what you can fix, and that's why I do a lot. And I always say that to patients when I'm doing this large workup. I say, because I'm looking for things that are treatable, because it would be a shame to miss something that I can easily treat. Right, so I'm looking for everything.
Oh yeah,
totally,
exactly.
So then, do you do the Midodrine?
Well, let's do the beta blockers first.
Oh, the beta. That we're doing. We're working on volume.
Yeah, actually. So when I talk about POTS and treatment, I will give a little explanation, which is the ways we approach it are we can address volume, we can address heart rate, and we can address how to boost your blood pressure. Okay, and there actually are different things, and I think it helps patients understand. So the beta blocker is used initially or primarily to decrease that tachycardia, to improve filling and improve stroke volume and cardiac output. Okay, the problem is that beta blockers, the main reason they were invented was to lower blood pressure. They're an antihypertensive drug. So my usual first line drug is propranolol, which is the oldest of the beta blockers. And as an antihypertensive, the dosage is like 40 milligrams 4 times a day, so 160 milligrams, okay? I will start with a dose of 0.5 milligram, 5 milligrams, half a pill, 5 milligrams once a day in the morning.
So do I.
All right, and titrate up from there. So classically, the patient may say, well, I already tried that and it almost killed me. Well, what dose did you start with? 20 milligrams 3 times a day.
Oh my God.
Not me. I mean, from some other
No,
physician.
I know, yeah.
So
I can only imagine what that would have done to a patient that's not hypertensive.
Exactly.
Yeah.
So this is a tightrope. You want to use the beta blockers so that you have enough to slow the heart rate down, but not so much that you actually cause low blood pressure.
Right. I wish you make sure that the blood pressure can at least sustain any beta blocker therapy. Right. That's of course the first thing to do. The thing that worries me about beta blockers is that I remember way back when in medical school, even learning about how to treat hypertension, they talked about how beta blockers can downregulate beta receptors. And so and they used to say, I don't even know if it's true anymore because I know there are a lot newer beta blockers on the market, but they used to say that once you're on beta blockers, you can never come off because you've changed the population of the beta receptors of the heart. And so forevermore, they're going to rely on beta blocker activity to manage their rate.
Yeah, I haven't
Is that not true?
Experienced that,
Okay.
and I actually would have thought it would be the opposite, meaning as with so many of our drugs, when we block the receptor, the body doesn't like that, and it makes more receptors to try to make up for it.
Maybe it was upregulate the beta.
Which is why when you remove the drug, they have a hypertensive episode.
Right, so maybe it was upregulation of the receptors.
So I haven't seen it be a problem.
Okay.
I like propranolol because it's old. So it's been around forever, so we know it well, or I know it well. It's, of all the beta blockers, it's the easiest and the most flexible in terms of dosing. It comes, the smallest pill is 10 milligrams versus metoprolol and atenolol and the other alls, which are higher milligram pills. And I know its half-life, which is short. So if there's a problem, we can stop it quickly. However, that's, as always in medicine and treatment, that's a double-edged sword. It's a short half-life, so patients can sometimes go peak and valley, peak and valley. This is something Andy Maxwell talks about a lot. And so I will, as per Andy Maxwell, once I've established that this helps and works, I will quickly shift them over to Natalol, which is long-acting propranolol.
I like Natalol. I use more of that than I do propranolol these days.
So I use it, but I usually start with propranolol. The problems with the beta blockers as a class, and propranolol, Natalol, and metoprolol in particular, is that they all can cross the blood-brain barrier and patients complain of fatigue, which was really eye-opening for me because back in my New York City internal medicine days, routinely we knew it would do that, but mostly only in older patients. Whereas these patients can be 20 and 30 and they have terrible reactions to the beta blockers. They get fatigued and worse brain fog. So that's an issue. Atenolol has less blood-brain barrier passage, so theoretically better tolerated, and sometimes it has been better tolerated.
Okay.
You probably have come across this. Well, patients will often say, oh, no, I'm not going to take a beta blocker because it'll make my mast cells degranulate and I'll have a flare.
I have definitely come across that.
I've never seen that happen. Okay, I know it's written. I know it's all over the internet. All my patients teach me this. I've never seen beta blockers flare somebody's mast cell.
I had one, and she actually had to go to the hospital.
Really?
She had a severe mast cell flare. She had to call 911.
Might have been an excipient.
It might have been. You're absolutely right.
That's what I would say.
Yeah. It was just that one patient, but it always stuck in my head. And I guess, I don't know why, maybe because I'm a neurologist and you're an internist, so have much more of a comfort level with beta blockers, is because they were antihypertensives to me. I do a lot of beta blockers when the heart rate is clearly way too elevated, but I don't do them as much as I think you do, or as much as many of the other doctors that we work with do.
I go to
the other drugs.
Yeah, but I think I want to hear what those are, but in a second. So another value or among the other values of beta blockers is are there other activities? So in the internal medicine world, beta blockers are used for blood pressure, heart rate, angina, which is cardiac disease, stage fright, performance anxiety, essential tremor, okay?
Right.
So all of those things are improved by blocking the beta site, okay? So when that patient stands up and their brain says, oh my God, there's no blood coming in, there's a tiger chasing me, and pours out sympathetic nervous system signaling, the beta blocker can help with that too and mediate or ameliorate this overwhelming adrenaline rush.
Yeah, because there are beta receptors elsewhere, right?
Exactly. So you're kind of getting a two for one.
It does make sense for sure, and I've definitely read about it, and I know that, again, that's part of what a lot of doctors who see our kinds of patients will do. And I definitely do them.
Right.
I just always, I think of that, I see them differently, I guess.
So what do you start with instead of beta blockers?
I actually do start with fludrocortisone often because, like I said, I sort of see it in the opposite direction, though I don't disagree with, I mean, who knows, right? And then I do Midodrine and I do pyridostigmine quite a lot.
So I do the Midodrine.
And I've been doing a lot of Corlinor lately.
Corlinor I love. Let's come back to
I love Corlinor.
Corlinor is
I think it's going to be my first line drug soon.
So we'll get there in a second. So Midodrine, for people watching, is a drug which literally raises the blood pressure. It's like a bicycle pump filling up a tire. Okay, and it can be very effective. I haven't seen it work as well as I'd like, partly because of tolerance issues. It can cause some very funny side effects which people don't like. And it can overshoot the mark. If you're supine, it doesn't know you're supine, and it keeps your blood pressure going up, and that might be potentially risky. But some patients, it's game-changing, no question.
Yeah.
Game-changing.
Yeah.
And then pyridostigmine, you're a neurologist. You start on the pyridostigmine. It's your drug.
It's a acetylcholinesterase inhibitor. And so, obviously when you Google it, it's used mainly for myasthenia gravis, which is an autoimmune disorder of a neuromuscular junction where there's not enough acetylcholine in the neuromuscular space. And so we use pyridostigmine, otherwise known as mestinon, to inhibit the enzyme that breaks down acetylcholine so that there's more acetylcholine to talk to the muscle, so that these patients with myasthenia gravis don't have as much fatigability of that muscle. And so and I explain that not because I just want to explain it, but because I do think it applies to our patients who do have fatigue of the muscles.
It's also good to warn them, because when they Google it and they see myasthenia gravis, they think, why didn't you tell me I have myasthenia gravis?
Exactly. And funnily enough, I do usually check that receptor, so sometimes I don't often find it positive, but rarely I do. But so when they say to me, do I have myasthenia gravis? I say, no, you don't. But I do explain what the drug is and what it's used for. But it does increase acetylcholine, which again is the major neurotransmitter of the parasympathetic nervous system. And so I find that it really, with it, more acetylcholine in the space between basically the nerve talking to the muscle, there is improved activity, improved messaging, improved signaling, improved action potentials. And I find that patients really, really benefit. It improves fatigue. It has improved brain fog in many of my patients. It certainly has improved gut motility. I mean, as you know, and this will be in the next episode, a lot of these patients have slow motility, dysmotility, gastroparesis even. It improves that. And it really does improve a lot of the POTS-like symptoms. So I really like that drug. Plus, it's safe. What I also like about it, it's got a fast onset of action. It's got a short half-life. So I tell patients, which is why you have to take it. I usually start twice a day, to be fair, but I always go to 3 times a day once I know that they're tolerating it. Although it's very well tolerated, I have very few side effects from it at the dosages that at least I use for this indication.
What doses do you use?
I start with 30 milligrams twice a day, which is a really low dose. I mean, so like a myasthenia gravis patient, I would start 63 to 4 times a day.
I start even lower.
So. So it's tolerated really well. So I usually titrate up fairly quickly, but it's got a short half-life and a fast onset of action. So within a couple of days, even a patient will know if it's helpful at all. So I like that about this drug.
I love pyridostigmine because I love the mechanism of action and the way it works, just from a sort of biologic.
Sounds
sounds so cool, the way it decreases the enzyme so you get more neurotransmitter, and I love that, okay? But I've been very disappointed in how well it works with patients, and I don't understand it. Based on how it works, and based on the fact that virtually all these patients have autonomic nervous system dysfunction, improving their neurotransmitter level, acetylcholine, should be the game changer for every single one of them. And yet I don't get such great results at all. I try it so often, and I have some patients who do great, but most of them it's like,
Well, we should compare notes because maybe it's a symptom thing, right? So I think that if they need more parasympathetic dominance, I think it can be very helpful. If there's so because you could have a predominance of one over the other, and in fact there's a lot of disorders that are when they're evaluated for that, it's like, is there a sympathetic predominance here, is there a parasympathetic predominance here? It's sort of this niche area of the autonomic disorder world that we talk about, and so it could be a matter of symptoms that you're trying to treat that aren't responding.
So would you have a way of using symptoms to guide a decision to try it? Meaning, if you have these symptoms, it's more likely to work than in
For
these
sure.
symptoms.
If it's classic POTS, I don't even think about it. If, like I said, they have a lot of fatigue, they have a lot of muscle weakness, certainly if they tell me that one of their triggers is even mild exercise, like going for a short walk, for example, certainly any kind of dysmotility kind of concern, I will always give pyridostigmine.
Yeah.
Oh, even if I try another drug in the same time, because it's really not contraindicated with most of the other drugs that you can use.
I mean, I still use it all the time. Maybe I just had too high an expectation. I like the idea.
Maybe you need to go high. Maybe you need to start higher.
Well, no, I keep tapering up. I don't give up at 15.
You don't give up.
No, I just do that out of caution. No, I won't give. Assuming no side effects, I'll push to 30, 60 3 times a day. I just don't get the results I want to see. And then some patients, not a small number, complain of diarrhea because it's working so well. And I get some patients complain of fatigue with it.
If they get diarrhea on the dosages, so how high would you go that patients complain of diarrhea?
I've seen it at 30 3 times a day.
Wow. See, so those are like clues of like a dominant component of the autonomic nervous system, right? Because that's a cholinergic activity, and they shouldn't have diarrhea at 30 milligrams 3 times a day. So it does give you clues and insight into their autonomic function, and that I can go down rabbit holes and not worth our time, because I think we're actually running out of time. But
we haven't even scratched the surface
I
yet.
know, exactly. I love the autonomic nervous system. We need to do several episodes on this. But okay, so then Corlinor. Right.
Okay, so Corlinor is the game-changing drug of the century.
If someone's sitting in my chair and their heart rate is 130, they're on Corlinor.
Yeah, but you can't. It's so hard to get. I mean, if ever there was an example,
I just tell them to pay for it.
But it's very expensive. A clear example of the insanity of our system. It's Corlinor.
I know.
It drives me out of my.
But it is a game changer.
Total game changer.
And I can't pronounce its generic name.
Ivabradine. Ivabradine.
Yeah.
It's amazing.
Yeah, Ivabradine.
Has no blood pressure lowering effect. Slows the heart rate down. Period. And it works.
It works. It's I have yet to have tried it on a patient that it does not work for.
Yeah, it's a great drug. So basically, I go through my speech. You'll never get it approved. Buy it from Canada, where it's 1/20th the cost.
Right, which is such a travesty.
It's infuriating. And I have no samples. So I say, maybe you can find a cardiologist with samples. And then the cardiologist says, I'm not giving you Ivabradine. Why would I give you that?
Right.
So it's...
No, it's true.
So
what I try to do is I ask, and again, if they can afford it, I say, please pay for a month and then tell me how much it works. I'm going to document it. And then I'm going to use that as fodder to your insurance company to say all of this stuff didn't work. I was going to say all this shit, but we curse in this episode?
I'd like to know if we can, because I keep trying to control myself. It'd be nice to not waste
to drop F-bombs here
brain
and there.
energy on censoring.
But people are paying for this. We can curse.
Okay, goddammit.
But and then I make an appeal to their insurance company. I say this is the only thing that has helped give them any quality of life back. And I would say 50% of the time I finally get it approved, but it still is not a guarantee.
I mean, I've had it occasionally approved, but it's such a pain in the ass.
I know, but it is such a game changer for these patients.
And the thing is, the cardiologist can get it approved. If you can find, I'll tell the patient, if you have a cardiologist, they'll get it approved. They got that big C in front of their name. They'll get it approved. I only have an I. It means nothing to the insurance company. So
is that how they label us?
Yes.
I didn't even know that.
Well, I don't know if they but they label this subspecialty. Okay. That's why you can get an MRI, cervical MRI approved in a second, and I have to sit on the phone for 25 minutes with some idiot, because you're a neurologist and I'm just an internist. Anyhow, Corlinor, Ivabradine, it is a great drug.
I agree. Do you do IVIG for POTS?
I would if I could get it approved. If you think getting Corlinor approved is hard.
Well, as you know, there's an autoimmune component many times, not always,
of course.
But enough times where I think that IVIG can be helpful. And there's no doubt that when I have at least satisfied my quest to decide if there's an autoimmune component for this patient, and I decide that there is, and I get IVIG, I would say 90% of those patients improve.
Right. So it's
a selection bias for sure. I say all that to say that it's
Dysautonomia International is running another trial now in Texas, I think, for IVIG for POTS. Mm-hmm. Hopefully that will show how clearly positive it is, and then the wonderful people at the FDA will add that as an indication, so the insurance company can't say there's no FDA indication, you can't have it. which is how they get out of it.
I know.
Even though they know it works.
I know, but if you can get a diagnosis of autoimmune autonomic, ganglionopathy or autoimmune neuropathy, autonomic neuropathy, and I use a positive small fiber neuropathy skin test to do that. Yep. Right, so I make that argument that this is an autoimmune autonomic neuropathy, not approved. But some insurance companies, shockingly enough, when I use that diagnosis with a positive skin biopsy, usually a positive QSART, that's why it's important to do the autonomic testing sometimes.
Will they accept that diagnosis
they do.
Without the antibody?
Without the antibody, they will. Yeah, because those are objective and they can't argue it. And then I give a whole clinical picture. Yeah. Right, and
how much time does that take you?
Oh, please. I literally have to like cancel days to work on these things.
So to our viewers, this is why doctors quit. This is what you're hearing is why doctors are quitting. Not just doctors like us. I mean, we're not quitting. We've opted out of the insurance system, but we're still tortured by it. But it's why other physicians just say, the hell with this, I've had it. I can't deal with the insurance companies ruining our lives and preventing me from taking care of patients. Yeah. End of editorial.
There's so much to be said. The insurance company is just, But so I find that IVIG to be very, very helpful.
Have you found plasmapheresis?
Oh, I think that's a game changer. But that I have not had any success in getting it covered by insurance. Yeah. And I think that's partly because it's sort of this, I think historically plasmapheresis was this inpatient kind of crazy procedure, and insurance companies haven't yet caught on that we can do this now outpatient, and it's actually more efficient than IVIG, and faster too, and more effective. Right. And so it's just not on their formulary, so they won't. I can't get it covered at all. So patients have to pay out of pocket, so it's very expensive.
And one of the bottom lines here, we're moving past the usual pharmaceuticals and drugs, is that almost any intervention that modulates the immune system can help patients with POTS.
Yes.
So that includes low-dose naltrexone, which we haven't really discussed at all, but I've seen POTS get significantly better just with this tiny pill. And at some risk, I'll say I've seen patients who, if they receive exosomes, their POTS is gone. It's extraordinary to see, without any change in any medicines or anything else.
Well, it speaks to the immune component of POTS and autonomic dysfunction, but it also speaks to, especially the exosomes, there's a degenerative component to this, right? So if we regenerate, we allow these cells to sort of, take a deep breath and go do their function as they were meant to do, then there's improvement. And I think that these kinds of things need to be explored further, for sure. And I definitely use LDN for a lot of things, and so we can certainly focus on LDN.
Yeah, actually, I give every patient LDN. Yeah. So we should probably talk about that
LDN
separately.
can be its own episode.
And before we run out of time, I mean, we didn't mention calcium channel blockers, but they can be used to slow down the heart rate as well. I don't use them much for other reasons, but they can be used. And Ritalin or some of the other stimulants can actually be very helpful with POTS and raising the blood pressure.
They could sometimes be triggers of POTS, though, right? So we actually didn't talk about medications as triggers of POTS. So like the TCAs, the tricyclic antidepressants, even the SSRIs and the SNRIs, but also sometimes stimulants. Yep. So you have to be careful of that as well.
I think it's a dosing issue.
It is a dosing issue.
I mean, certainly, Ritalin can raise the heart rate, but it can definitely help with blood pressure.
Yeah, and when there's I should add that, like even for propranolol, but also calcium channel blockers, when there's migraines and headaches also as a component, I do think about those drug classes a little bit more because we can treat that as well. So so there's a lot of things that overlap that you can will help choose what medication you might want to start with, might want to add, might want to go to next. But there are a lot of options for treatments. And I will say that I think POTS is one of those things that I feel like when patients ask, like, will I ever feel better? With POTS, at least, I feel like there's a good chance that they will, because there's a lot that we can do. And we didn't even get, and we're out of time, but we didn't even get into some of the more like IV nutritional kinds of things that are also helpful. And so,
but I think it's what you're saying is a good ending point for people. POTS is a completely actionable, low-hanging fruit. We can treat POTS. First, you have to get it diagnosed.
Yes.
Okay. It is completely treatable. There of course will be some patients where we can't make progress, but almost always we can make a big change. The other thing I'd like to emphasize as we finish, which I hope people heard, is that it is all trial and error.
Yep.
We start with a dose and we see how it goes. If it doesn't work or it causes a problem, you move to the next option, the next intervention. We don't know all the right answers. We have to trial and have error and figure it out and titrate and manage.
Right. And one last thing, just with regards to treatment. Sometimes, if we've tried everything and nothing is working, look at the anatomy, right? Because we know that correction of
exactly.
CCI will
Right,
improve
right.
it. We also know that when there's correction from mouths, which we mean in arcuate ligament syndrome, which is severing the celiac ganglion. And so severing that seems to improve POTS symptoms. So sometimes some of the ganglionic blocks will improve POTS symptoms. So sometimes it's actually about the anatomy, and all of our medications and everything that we've talked about won't correct the anatomy.
So I'm going to broaden that. I know we keep saying we're going to stop, and I think we said this very, very early in the series, if something's not working, go back to the beginning and say, what am I missing?
What am I missing?
Look for infection. Look for a neuroanatomical problem. Look for SIBO and leaky gut. Look for, all these different things. Again, that's part of this whole trial and error. We don't know everything. We just have to keep trying.
Well, if you're missing it, then everyone's missing it. I can assure you of that. So we'll end there.
All right, finally.
Thanks for listening again.
Thank you very much. This was actually a lot of fun.
Yeah,
for us.
we love talking to one another. We hope that you love listening to us talk to one another. And again, we want to talk about what you want to hear about. So please just send us topic suggestions and questions.
And we promise we'll get to SIBO and LDN
we'll get to
and
everything. Yeah, this subscription is worth it. Trust us.
Thank you.
Bye.